Hello everyone, welcome to Facebook Live. I'm here at Regenx headquarters in Broomfield, Colorado with Regenx founder and Chief Medical Officer Dr. Chris Centeno. And today we're going to talk about what is interventional orthopedics. And so Doc, what is interventional orthopedics?
Yeah, interventional orthopedics are sometimes called interventional orthobiologics. It's a different thing than just sticking needles into joints and doing blind or simple ultrasound guided injections. It's really an entire specialty unto itself. So what that means is, for instance, in the shoulder, it might be using ultrasound guidance to precisely inject a tear that's in the rotator cuff, or at the superior labral anchor where the biceps attaches, targeting that area either under ultrasound or x-ray guidance, or in the knee, targeting specifically the ACL ligament where the tears are, or also in the knee, that first one I just described in the ACL uses x-ray guidance. Maybe it's injecting the patellar tendon because that's where they need to go. So it's precise targeting, and it takes a while to learn that stuff and become really good at it. So your average orthopedic surgeon can't do it. Your average family doctor can't do it. Nurse practitioner or a physician's assistant can't do it. And I think it's the single biggest difference in quality, meaning you've got doctors around the country, maybe 100 to 120 that do it at this level, meaning they're doing orthobiologics, injecting bone marrow concentrate that has stem cells or platelet-rich plasma, or other things at this level, and you've got everyone else kind of operating down here at this level, and patients don't really understand the difference. Now, I can tell you the difference in 5 minutes or less, just by looking at a website, trying to see who's doing the procedure, but most patients don't get that, and they don't understand that. So it's a weird thing, right? We go to a store and we can tell, oh God, this is a much higher quality product than this one, but medicine, not so much. You kind of walk in and you get what you get. So doing your homework here on interventional orthopedics is important.
Right, exactly. And so you may have mentioned this as I was looking at something else. What are the two main tools that are used to image all of this guidance?
Yeah, so the two main tools we use in interventional orthopedics are x-ray guidance, or real-time x-ray called fluoroscopy, or we use ultrasound. Now they're really interesting in that there's very little overlap between those two, meaning that I talked about an ACL injection. Because the ACL lives in a bony tunnel, really x-ray guidance is the way to go. You can see more of the ligament on x-ray with contrast than you can if you were to use ultrasound. Having said that, I talked about the rotator cuff. For the rotator cuff, ultrasound's the way to go because you can see the tendon quite nicely. And fluoroscopy there would underperform. So you really need both in the office to be able to do this stuff right. And the problem is that's pretty expensive to pull off, meaning that having both of those machines and creating a room for both of those machines that's properly outfitted is about a $300,000 affair, meaning that you would have to have a fluoroscopy machine, an ultrasound machine, a crash cart, a specific table, special lining in the walls, etc. That's really not what most clinics have. They're not spending $300,000. They're taking substantial shortcuts.
And your point about not being able to learn it, especially both of these, in a short amount of time, reminds me of a case I know you took care of somebody who did an ultrasound-guided injection in an ACL and didn't get it right, and they came to you to get it fixed.
Yeah, and it couldn't even be fixed, regrettably. So that was a professional quarterback who had gone to a famous sports medicine clinic, who had gotten an ultrasound-guided ACL injection. The doctor at that clinic really didn't understand how to use fluoroscopy, wasn't trained how to use fluoroscopy, so he did it with the tools that he had. The problem is, if the ACL is this long, the bone marrow concentrate only went about halfway up and dumped out the back. So the top part of the ligament never got covered, and since the doctor could only see the bottom part of the ligament, he didn't know that. So guess where the ACL failed? It failed in the top part where none of the bone marrow concentrate made its way. Now, had that been done under x-ray guidance, we would have been able to put it in both parts, and I suspect that that quarterback never would have needed an ACL reconstruction surgery. So it was not one I could easily fix after the fact, but it could have been done right from the start, and the average patient wouldn't know the difference at all. He obviously, this is a very smart guy, this quarterback, but he didn't know the difference until I told him.
Yeah. And so along the same lines, Terry asks, if this is what's needed, why are doctors allowed to do what they do without having this knowledge?
Because it's the Wild West, Terry. Right now, unlike, let's take, for example, a physician that goes through a spine fellowship to do interventional spine. There are certain guidelines of things he or she has to learn. They've got to take a certification test at the end of that one-year fellowship. They've got to go take other types of oral boards, etc. So all of that is pretty well mapped out. When it comes to regenerative medicine, none of this is mapped out right now. So you can have someone who goes and takes a weekend course and calls himself an expert but knows very little, right up against someone who spends $300,000 on the right equipment, spends years learning how to do this right, and you would never know the difference between those two doctors as a patient. I would know the difference immediately, but you wouldn't. And that's the problem. It's the Wild West out there right now. And because it's the Wild West, it's all about the research, meaning the more you dig deep into this area, the more you'll be able to figure out what's quality and what's not.
Right. I want to encourage you to ask more questions. If you know someone who should hear this, a loved one, a coworker, please share this with them. Lamas asks, how many days do you need for a neck procedure?
Yeah, honestly, it just depends. I'm not quite sure what you mean by how many days you need. Maybe days recovery. It depends on what we do. So as an example, there are neck procedures where there's really no recovery time at all. There are neck procedures where I'd give it a day or two for recovery time if you had to travel. So it just depends on what we do, meaning we do, so this is a great example of interventional orthopedics. I mean, there are about 50 different neck procedures that can be done. Think about that. That's one part of the body, and there's 50 different procedures. Now, some of those are similar, like injecting the C3-4 facet joint versus the C6-7 facet joint. But then you get up to the C1-2 facet joint, that's a completely different procedure. You get up to the C0-C1 facet joint, that's another completely different procedure. If you're doing a cervical epidural interlaminar, that's a different procedure. Cervical epidural transforaminal, a different procedure. Injecting the supraspinous ligaments, a different procedure. Injecting the anterior longitudinal ligament, different procedure. The longus capitis and coli from the front, different procedure. The alar transverse ligament, different procedure. So we've just gone over a small fraction of what can be done in the neck, and all of those have got to be learned by the doctor. And the number of doctors who know all of those procedures I just described off the top of their head, we're now down to maybe, if we include the ALAR, 3 doctors. If I take that one out, we're about 100 doctors that have done all of those competently and a lot. That's it, 100 in the U.S. That's all you got.
Yeah. Lamas means upper cervical, so I believe we've talked with him in previous Facebook Lives about the PICL procedure.
Yeah, so that would definitely be, if you've got a long trip, give it a couple days afterwards.
Let's see. Marianne asks, when will the RCTs for low back pain with PRP be expected to be completed?
Low back pain with PRP. Again, so it's another good thing to discuss here, that there are 20 different causes of back pain. So we've got back pain that can come from the disc, back pain that can come from one of 10 irritated nerves, back pain that can come from a disc bulge at multiple different levels, back pain that can come from fascia, from muscle, from loose ligaments and instability. As far as PRP, randomized controlled trials for back pain, we have 2 or 3 that are out there that I know of, and we'll probably see another 3 or 4 being produced here in the next year or 2. That doesn't mean that we're going to get wide insurance coverage for that, but at Regenix we have insurance coverage through about 7 million people. We're bringing on, I heard today it was 70 new companies. I heard it was 50, but 70 new companies as of January 1. So these are companies that have full coverage for all of these procedures.
Yeah. Let's see. Knight asks, she was told at a stem cell seminar that stem cells know how to find their way to fix the problem. What are your thoughts on that?
Yeah, and Santa Claus comes through the chimney. I think what you've heard there was a little tiny bit of knowledge, the concept that stem cells can home to a problem in a local area. So for instance, if I create a new injury, cartilage injury in a knee, a stem cell that's in the joint might find its way there. But if you take that knowledge to the next level, what you will learn is that if you place stem cells directly on that cartilage lesion, you'll get much better repair of the cartilage lesion than if you just put them in the joint and let them home there. I think what you're hearing there is from someone who doesn't really know a lot about stem cells. They're trying to justify why they would put them in an IV. Now, why are they putting them in IV? Because any idiot can start an IV, meaning that we teach everyone from RN nurses to LPNs to medical assistants to people with no formal medical training like EMTs how to start an IV, meaning that's one of the simplest medical procedures that's possible. And that's why it's being used. It's being used because it doesn't take a lot of money to do. It doesn't take a lot of expertise. The people that start IVs are very inexpensive for a medical clinic to hire. But it's not being used because that's the right way to deliver stem cells to someone. The biggest problem there is there's what's called a pulmonary first pass effect. So 97% of those cells will end up in the lungs and not where they should be. And only about 1 in 10,000 will end up, for instance, in the brain. So why would you give them IV? Because it's simple and easy for the doctor, not because it's the best way to do it for the patient. It would actually also be the most risky for the patient because those cells can go anywhere. So if you've got small tumors in your body, as an example, we know that if you inject mesenchymal stem cells into or around tumors, they can make tumors bigger. So you don't want to put stem cells anywhere close to tumors. If I put them IV, I've got no idea where those cells go. Tumors have great blood supply, so they might find their way into a tumor. That's why we never inject cells IV here, ever. That is off our list.
Barb asked, she had a stem cell procedure in one knee, PRP in another. If she needs a knee replacement in the future, is there a possibility of her having that combined with surgery, a Regenix procedure with surgery?
Yeah, it's interesting that you would say that. I don't know that it will help a lot. We have certainly seen patients who have failed knee replacements, who usually have pain either from the prosthesis or pain around the soft tissues, or pain that was never actually from the knee in the first place, i.e. it was from their back, and we have treated those other things. But as far as, will stem cells help your knee replacement go any better, I don't have any data to support that right now.
And a quick answer, would Medicaid be of any benefit for these procedures?
No, Medicaid Medicaid and Medicare could be some of the last groups to cover these. So what we'll generally see, and the normal adoption of all procedures, are we'll generally see self-insured companies like we're going after now be the first to adopt new and innovative procedures because they're writing the checks. They want to reduce their spend by giving their employees better stuff. Then we'll see insurance companies, private insurance companies, start to adopt a procedure, and then finally we'll see Medicare and Medicaid, but usually they're the last.
Mario asks, stem cell. What's the usual amount of time for stem cells to start working in the neck? A month and a half out would be too early to tell. Will the atlas bone align in place?
Yeah. So I don't. Have you had the PICL procedure or another procedure? Meaning that if we're talking about a PICL procedure where we're talking about tightening ligaments that hold those things in place, then the normal amount of time that we would look at would be 3 or 4 months before we'd even say yay or nay, this helped or it didn't help. So that 3 to 4 month time frame for that type of procedure would be about right.
Let's see. As spinal stenosis gets worse, let's see, moving by quick. I don't know if it's lumbar or cervical. Can it cause dizziness and vertigo? Dizziness and vertigo. These are lightheadedness.
Probably cervical stenosis.
Yeah, I would think so.
Yeah, so stenosis in the neck, just so everyone understands, or in the low back, is when the central canal, where the spinal cord goes through, gets too small for any number of different reasons, and that can cause pinching of the spinal cord. Those are not common symptoms with cervical stenosis. Usually those are common symptoms with upper cervical problems. So, and usually stenosis happens in the mid to lower cervical spine. So usually those are not things we see with cervical stenosis or related to cervical stenosis.
Mario, who you answered before, had, it sounds like posterior upper cervical stem cell procedures done.
Yeah, so usually those, we would expect the person to feel better within the first 1 to 2 months, different from that PICL procedure. So if you're not feeling better within that first 1 to 2 months, maximum 2 months, then you might need that PICL procedure, which goes after the ligaments that hold the head on that can't be reached from the back. The doctor would have to go in through the front. Now, we're the only place on earth doing that procedure right now, so that would be done here at the Colorado HQ site.
Gabby, I'm getting to your question here. A lot asks if this, any of these regenerative medicine procedures would be beneficial for Osgood-Schlatters syndrome.
Yeah, so it's interesting. Osgood-Schlatters, just so everyone understands, is usually a big one in teenagers, and it's somewhat related to activity and growing, and it's where the patellar tendon attaches into the bone. In the front of the knee, you tend to get a big bump there and it can be painful. We've treated Osgood-Schlatters kids with simple regenerative procedures like prolotherapy, and they tend to do very well with that type of treatment. So even simple stuff will basically help that kind of problem, meaning all it really is doing is to give the adolescent a couple more bites at the healing apple there and let their healing mechanisms kind of take over and solve the issue.
With the upper cervical instability, Lamas asks if he has a MRI, is DMX necessary?
Usually it is. If you have an MRI that's a flexion extension MRI, and we can see obvious instability for looking at things like grab oaks or other static measurements in flexion versus extension, sometimes it wouldn't be necessary, meaning we'd be able to make the call of instability based on that movement-based MRI. If it's a static MRI, it's less likely we'll be able to make that call just based on the MRI, and we would need a DMX.
Marianne asks, are cysts in hips same as bone marrow lesions and considered to be dead bone? The Cayman procedure is resolving cysts in hip cases, so is it actually regenerating bone? How many cases so far?
Yeah, so just so everyone understands, a bone marrow lesion is an area of swelling within bone that you can see on MRI, and it looks like there's fluid in the bone. That's also called a bone marrow edema, area of bone marrow edema, or BME, so BML or BME. Then you've got a cyst, which is an area of walled off dead bone. So a cyst is what it sounds like. It's an area where the bone has died and the body's kind of walled it off into what looks like a cyst elsewhere, but this one's in the bone. When it comes to bone cysts, we have seen them resolve with the Cayman procedure, but I can't say it's something we focus the procedure on. It's been more that we have noticed them go away in certain circumstances. And that's generally when we are injecting directly into the cyst. In fact, I just did one of those cases when I was just down there during Thanksgiving. So yes, it's possible to get rid of some of those cysts. Others are probably not going to go away, so we'd have to look at the MRI.
Randy states, I believe PRP can benefit people, but why are stem cell treatments so expensive when for the most part they do nothing? I've spoken to 100 people who have had a stem cell treatment and they got no benefit.
Wow, it's a lot of people to speak to that didn't get benefit. PRP is very effective for a lot of things. We use PRP about 80% of the time, 80% of the time. Only about 20% of the time do we ever do anything with a, quote, stem cell procedure. Now, there's lots and lots of different things out there called a stem cell procedure. We tend to use bone marrow concentrate. You can also use MFAT or microfat, meaning taking a fat sample and using a machine to or a kit to chop it up very finely. And you can also do things like using birth tissues. The problem with the birth tissue injections are there are no stem cells in them, meaning there are no stem cells in the umbilical cord products being sold, there are no stem cells in the amniotic products being sold. So not quite sure how to answer your question, meaning that we've got a large database of almost 20,000 stem cell treated patients. So there's definitely a response rate, more in some things, less in others. We also have 1 published randomized controlled trials. There are also about 20 randomized controlled trials published to date using stem cells. But again, stem cells as a blanket term is problematic because there's a lot of things being called stem cells right now.
Right, exactly. Gabby, I told you we're getting there. She asks, can there be too much time between PICL treatments? I'm going to ask you a couple questions. Is cracking normal after the inflammation decreases? And is there any connection between the SI joints and the upper cervical segments?
Yeah, so after any procedure like that of a ligament with bone marrow concentrate, you're going to see 1 to 2 weeks where the ligament is swollen and tight. So people generally during that time go through what I call a honeymoon period. They feel pretty darn good. Why do they feel pretty darn good? Because while they might be sore from the procedure, the ligament is swollen and tight, so they've got stability. Then after about 10 days to 2 weeks, that initial swelling goes down, and then you kind of go back to where you were, and things start moving around, popping, cracking like they were. And then at around month 2, 3, 4, usually more towards month 3 and 4, you start to feel better again because new tissue gets laid down and things start to get tighter again. So that's generally how that goes, whether it's a PICL procedure or an ACL injection, kind of the same thing.
Let's see. We were talking before we got on camera here about interventional orthopedics. I was in an orthopedic surgery conference this weekend, and I was just amazed at the amounts of new hardware that keep coming out. Joint replacements, partial replacements, a whole booth of things to remove a lot of this stuff. I know you see a lot of that kind of.
Yeah, I mean, it's very, very interesting. I mean, we see day in, day out, lots and lots and lots of stuff being put into people. Listen, I was just writing a blog this morning that quoted a British Medical Journal article that the evidence base for that stuff is what one Brit termed scandalously poor. Now, scandalously is not even a word we use in the English language in the U.S., but it's a very British way to say it. But yes, what he determined was about 80% of that stuff doesn't have evidence to show that it works. So it's really kind of strange. We don't have a lot of really good evidence to show that we should be doing this to people. And yet it's very easy to create, for instance, for lumbar fusion, a screw in China that literally takes $5 to make at the very highest level, maybe on the outside $20, and then mark it up and sell it to an insurance company here for $1,000. So because of those kind of markups, because it only takes not much to register or get that screw cleared with a predicate device, we see this explosion in orthopedic hardware. The problem is many times we don't have any idea that it's really an effective thing to do for a patient, but it's certainly a very profitable business to be in, which is why you see all of these booths at these conferences.
And I spent some time looking at screws. They really don't look like anything fancy.
No, they're not. I mean, sometimes they're made of fancy materials, maybe titanium,
right,
etc. But literally, you could take the same screw that we sell for $1,000 in a lumbar fusion and make it to the same exact specifications, and it would probably sell for about $5 at Target. Maybe on the outside, $10 if it was made of some exotic material. The Home Depot price is $10. The medical price is $1,000. Same screw. The only difference was it got put through a $1 sterilizer, usually an ETO gas sterilizer for $1. So it's $11 versus $1,000. Same exact screw.
Right, and I've heard some instances where the surgeon will get a package of sterilized screws, 10 of them. They have to buy 10, but he might only use 6. And so that goes to our healthcare costs.
Yeah, I mean, it's quite the game. So what we try to do in interventional orthobiologics or interventional orthopedics is to get rid of all that stuff. We believe that we can, it's one of the reasons why we've been so successful working with large self-insureds, because we can get rid of those costs about 70% of the time. So in 70% of the patients, we can treat 70% of those using stuff without all those screws, without all that hardware, without putting the patient in the hospital, without putting them through an ambulatory surgery center, in the office, for much, much less money.
Right. And so some of the things flying around that conference were about 30% of people who are recommended surgery, only about 30% will actually move forward with it, and about 30 to 40% of those people who are not or who see a surgeon are not surgical candidates, and so they're left with like nothing else to do other than potentially interventional orthopedics.
Yeah, so obviously, I think patients will always choose a less invasive option if you give it to them. The problem is many times in orthopedic practice, it's not provided. Even in orthopedic practices that do some, for instance, bone marrow concentrate or PRP, oftentimes it's not provided, meaning that I've got colleagues that work in orthopedic practices as non-surgeons. They're doing injection-based PRP as an example. They could never touch an ACL in that orthopedic practice. They wouldn't be allowed to. Now these are ACL patients that we can treat all day here. 70% of those we can get them to heal without ever putting them through any surgery, but only a precise injection of bone marrow concentrate into that ACL. But my colleagues that work in these practices can't do that work. They can't compete head-to-head like that with surgical procedures that are literally making the payroll each month.
Gabby asks, she keeps hearing things about whether the posterior longitudinal ligament can be injected in cervical spine. Can it actually be injected? How many people have had this done? Can all the doctors at the clinic do this injection?
So Gabby, yes, you can inject the posterior longitudinal ligament in the cervical spine. You would have to go an intradiscal approach from the front, where you would go into the disc and to the posterior longitudinal ligament. So yes, it's possible to inject, just like the same ligament's possible to inject in the low back. Again, in that case, you come in from the back part, so it's closer. But yes, it's possible to inject. Here at the Colorado HQ site, yes, all of the doctors here should be able to do that. Certainly Dr. Pitts, Dr. Schultz, myself, Dr. Merkel, all of those doctors would have done a lot of cervical intradiscal injections and would be able to pick that up.
Nancy asks, could cyst fluid collection in the knees, bursal, ganglion, or parameniscal negatively affect Regenexx stem cell and PRP injections?
So those are cysts in a lot of spots. So there's a couple things that were described there. One was a cyst associated with a meniscus or a meniscal cyst. Another one was cysts that might exist around tendons. Another one were cysts that might exist in the back of the knee, like a Baker's cyst. So the answer to your question is we can treat cysts in those areas, but that would be on a case-by-case basis, meaning that sometimes the cysts are loculated, meaning that they've got lots and lots of small compartments, and that makes them more difficult to drain and treat. Other times they're much easier to get at. Usually they're relatively easy to treat, and having a cyst is not a problem. But if you've got cysts in all those different spots, then that's something we'd have to look at.
Lamas asks if we have any advanced technology coming out in the near future.
We always have advanced technology coming out, meaning that, as an example, we're using machine learning to look at who's a good candidate for a knee stem cell injection based on 440 cytokines and growth factors measured from a 1/4 cc sample of someone's synovial fluid. So yeah, always working on new stuff.
That's great. Listen, I want to recommend, if you know somebody who needs to hear this, they're looking for some surgical alternative, please share this with them. We've got time for a few more questions. I think this will probably be our last Facebook Live for the year.
Yeah, I think so. I'm gonna usually I take off the last 2 weeks of the year. It's kind of my summer vacation, if you will. I don't really take a big summer vacation. I take 2 weeks off in the summer and 2 weeks off at the end of the year. So I'll be off for 2 weeks here, not doing Facebook Lives. And generally during the holidays, what I find it's a great time to kind of dial it back and relax a little bit. And even as a doctor working during the holidays, we tend to have a lot of no-shows. And it makes sense. People have family in town. They've got other things to do. So it's a good time for me to take a break. So I'll be taking a break.
Lamas, thanks for sharing this with the group. Mark's asks, front and back ribs come out very easy, cause a lot of pain. Have you had success with resolving this? If so, what percentage of patients would you estimate?
Yeah, so if it's the average patient who has unstable ribs, that's a high success rate procedure. We inject those under a combination of X-ray and ultrasound guidance. We'll inject the ligaments that hold the rib to the spine and or hold the ribs to the sternum, and then also the fascial ligaments all the way around. So 80% is a good success rate for those. Now, if you've got EDS or loose ligaments, then maybe a little bit less, maybe knock 10% off of that, but similar success rates there. So usually those are high success rate procedures when we're going after specific ribs and trying to stabilize those.
Barb asks, will you be hiring a surgeon to do knee replacements in your Colorado center?
No, I don't think so. I think we'll stay away from knee replacements. Listen, at some point, we've often talked about bringing in a traditional surgeon, and we actually interviewed one this last year because we would want that surgeon to mesh well with what it is we do. So we as yet haven't found that perfect person, but I'm sure we will at some point. But I doubt that doctor will be doing knee replacements, meaning that our goal is to do everything we can to avoid that. And one of the problems is in medicine is that you tend to get into conflicts of interest. So it's no different than anything else. If you've got someone doing knee replacement, they want to do knee replacements. If you've got someone trying to avoid knee replacements, they want to avoid knee replacements. So it's generally a good idea for us to have folks focused on helping people avoid big surgeries rather than people who make their money by providing big surgeries.
Just a couple more here. Lamas asks, is EDS worse than patients who do not have EDS just getting ligament damage? And then let's bounce off that. Gabby asks, what's best for someone with EDS, Prolo, PRP, or stem cells?
Yeah, so as far as do patients with EDS get more ligament injuries, the answer is absolutely. They've got loose ligaments, joints tend to get injured much more frequently. As far as what's better for EDS, I can only tell you what I've experienced through the years. I think EDS patients do quite nicely with Prolo. They tend to be less responsive to PRP in my experience going into the ligaments, and they tend to be the most responsive to bone marrow concentrate. So frequently, as an example, we'll treat EDS patients with bone marrow concentrate in the worst areas, but we'll touch them up with prolotherapy in those areas. So a good example is my niece, actually. It's the first year, I think, in, probably 5 years that my niece is not coming to Colorado. She's got a pretty severe EDS variant, and we would treat her at least once a year with either bone marrow or Prolo. These last 2 years, we've more just had to do Prolo touch-ups, and she's good. I mean, it's been a 5-year project with her where we've done bone marrow Prolo, bone marrow Prolo, 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 bone marrow Prolo, Prolo, Prolo. But she's done really, really well. She's now actually been able to get strong enough where she doesn't need me, and this is the first year she hasn't traveled from the UK to here to get treatment. So I consider that a win.
Yeah. Barb asks, would you recommend a knee replacement if I needed it?
Sure. I mean, Barb, we turn people down all the time. What we do is a candidacy-based system here. What I mean by that is that you're either a good, fair, or poor candidate. So if you're a poor candidate, we'll tell you you're a poor candidate. Now, this is a low-risk procedure, and generally we offer low-risk procedures. So if you were to say, you told me I'm a poor candidate, you told me there's only a 1 in 4 chance this is going to work, will you still try it? I understand there's a 3 in 4 chance this might fail, but I want the 1 in 4 chance, then we'd probably allow you to do the procedure. But we tell you up front, there's a 3 in 4 chance this is not going to work, Barb. We'd recommend, as an example, you go get a hip replacement because we think that's far better, as a far better likelihood of working. Absolutely. In fact, there's not a week that goes by I don't have that conversation with somebody.
Speaking of hips, Marianne had PRP at L3 through S1 in Raleigh. Great. Has hip OA, multiple cysts in the femoral head and acetabulum. Considering what benefit of injecting into the hip or Cayman, any suggestions?
Yeah, so if you've got, that's a good conversation to have, because if you have more severe hip OA with lots of bone cysts, change in shape of the femoral head, it's much less likely that a Cayman procedure is going to be successful. There's very little chance that a bone marrow concentrate or a PRP procedure here in the U.S. is going to be successful. So that's generally hip replacement territory for the most part. Different in the knee, where we can see patients with severe arthritis who still respond quite nicely to bone marrow concentrate. In the hip, that's a different story. Hips tend to be much more resistant to treatment when they're that severe.
Kelly asks, how does Prolo PRP heal cervical discs and strengthen the ligaments? That could be a Facebook Live all of itself.
Yeah, so I think what you're talking about is extradiscal treatment versus intradiscal treatment, meaning that we try to stay out of the disc as much as possible. So I'll give you a great example. We were just pulling some data on this. We're probably only going into the disc now about 5 to 10% of the time. 90% of the time, for example, we're staying outside the disc and treating the entire functional spinal unit, meaning there's a reason why the disc has a bulge and is collapsing. There's a reason why the nerves are irritated, and that's degenerative instability. So we can usually help that by treating those ligaments, joints, nerves, etc., and not going into the disc. And then about 5 to 10% of the time, we need to go into the disc to treat that. So at the end of the day, as an example, I've got chronic neck and back issues. I'll have treated every once in a while. I have yet to have my discs injected, and I probably will stay out of the disc and ask these doctors here who treat me to stay out of my disc. Why? There's a 1 in 200 chance of creating discitis, which is an infection in the disc, if we inject the disc. That's a bad day for everyone. That's IV antibiotics, that's surgery. And even though we do lots of things to prevent it, a lot of times we're just stirring up bacteria that already lives in the discs, called P. acnes. So our mantra is, if you don't need to be in the disc, stay out of the disc.
Good. Two more and then we'll wrap it up. Lamas asked, why can't my ortho doctors diagnose upper cervical damage? Why do they say it's all normal?
Yeah, listen, you can certainly go to super specialists, usually neurosurgeons, who understand this stuff, and they'll be able to diagnose it. But the average orthopedic surgeon or neurosurgeon is really not trained to look for this stuff. Meaning, if I were to go up to the average orthopedic surgeon and tell me, and give them a neck MRI and say, measure a Grab Oaks on this, they would look at me like I had a third eye on my forehead. They wouldn't know what that was. Or show me where the atlantodental interspace is. Some of them might be able to figure out from what the words are, but they wouldn't know what that was. Or look at this DMX and show me, tell me if there's more than 2 millimeters of C1, C2 overhang. Again, they might be able to understand it from what the words were, but they wouldn't have that experience looking at that stuff. Now, there are specialist neurosurgeons that do upper cervical instability that would immediately know what all those words were. They would immediately know how to do all of those things, plus more. So it's like anything else. If you do something all day, you get specialized in it. All these things exist. There's lots of publications on how to do this, but it's a highly, highly specialized area where only 1 in 100 neurosurgeons would even know what the heck you were talking about.
All right, last question. Gabby asks, can she go to Cayman, have one doc draw her bone marrow and another one re-inject it?
Yes, that's done all the time in Caymans.
Right. All right, so any final words of 2019 before we get into a new decade?
Oh, God, that's right. We are entering a new decade. I didn't even think about that. Listen, at the end of the day, first thing is I want everyone to have a very safe and happy holiday. I know that many of you are in pain, and hopefully we'll be able to help as many of you as we can get out of pain. So have a happy holiday. And then second, this has been a really interesting year. I mean, we've seen all sorts of crazy stuff. If you read my blog, you've probably seen I did a blog on the exosome thing at the A4M conference. This is one of the largest aging conferences. And the FDA just came out with multiple warnings saying you can't sell this stuff, and yet there were people still selling it there. So things are way out of control at this point. Like I said, to start this, do your research and do your homework, because your job as a patient is figuring out doctor that's up here versus a doctor or a clinic that's down there. And I try to help you as much as I can on the blog, make those determinations on your own. But you don't want to be with the clinic or doctor that's operating down here. You want to be with those clinics or doctors that are more rare and operating up here. And that's the biggest advice I can give you in 2019. Find the guys that are up here. There are guys outside of the Regenexx network that are operating up here. They're few and far between, but they're out there. And obviously all of our Regenexx guys are operating up here. But do not end up going with a clinic that's operating down here, because that's some scary stuff. So have a wonderful holiday, and wish you all a new year, and we'll see you after the new year when we come back.
All right. Thanks, Doc.
Thank you.